whenever I think of having a speaker and then getting like the most overqualified speaker in the world, I think of Ahvie. He survived a large number of training programs in pathology and immunopathology and internal medicine and cardiology. And so you must like pain, all I can say. But we have a specialty topic to talk about, and he's going to share some information and case material about the use of therapeutic plasma exchange in cancer. And so I will let you come up.
Thank you.
This is a 45-minute lecture. We're going to run it properly for 45 for Dr. Herskowitz. So if you have questions, we will tackle them later or certainly in the panel discussions. So put your hands together, please, for Dr. Herskowitz.
Thank you. We'll talk about the guy who likes pain. We have Paul here to remind us all about pain. And I want to thank the naturopathic community and his leadership in there. But the question is, what is this guy doing here? 48 years ago, I entered pathology training as almost like a PhD equivalent, as I wasn't ready to go on the wards. So I got trained in pathology and immunopathology when it first emerged. And I noticed something, because I had a tendency to look at evolutionary biology at that time, and I noticed that we have a place in the universe on Earth that is much more complicated than is taught in school. And we have a lot more in common with earthworms than we do with our next door neighbor. And conceptually, we have this concept of system biology that wasn't a term then. So I had expert advice and conversations with a lot of Albert Einstein's friends at the Albert Einstein College of Medicine who were in their 90s, brilliant pathologists who understood that concept. But then when I went to medicine at Yale and cardiology at Hopkins, nobody understood what I was talking about. Literally nobody, except for the basic scientists. And there's a schism that's between the basic sciences and the medical people that is growing and growing and growing to the point where right now we have hospitalists taking care of patients in the hospital or experts on the clinical side that know very little basic science. And that's the way it's taught in medical school. There's so much volume to memorize that they lose the concept that we are a system like many other animals are, and that we have to coordinate our approach. So this is a brilliant time to speak after Paul does, and because he gave us the perspective. But after pathology, I thought that there were three things I had to think about in all aspects on every patient. Although later on, when I was at Yale, they said, don't get Herskowitz as your doctor because he'll want to do an autopsy. That was not true. But I thought someone had to govern all the systems, and that ends up to be the mitochondria. Something has to guide the second intelligence, and that's the biome that we didn't think about in those days because we were ruining it. We just didn't know about it in the 70s. And then the brainstem is the superhighway going into the brain. And without thinking about those three super conserved millennia concepts, that we would miss the larger picture. And today I'm going to go over what I mean by that and use a technique called plasmapheresis, which I'll explain why I got interested in this in the first place. So when you think about cancer and you say, well, I'm not good enough at it, I can't seem to help everybody, I'm missing something, then you say, well, what things can do a lot of different benefits, even if I don't understand it all. So we're talking about a lot of questions on HBOT. They talk a lot of questions about, we don't talk about hyperthermia because it's not done so much in this country, but that's another way. You can have therapeutic targeted vaccines. It's, again, not our realm of expertise here, at least not yet. And therapeutic apheresis or plasmapheresis is one of these entities that can do a lot of different things, whether it's on the tumor itself or it's on the tumor microbiome. Lasers is another one, and ultrasound, and there is a laser vendor here. And I use that again for a global impact, whether I understand every part of that global network that it's interfering with. I don't know. So then of course, we all have to do lifestyle. We have to do everything that we do. But on top of this, I'll want to explain what happened in my clinic after we added plasmapheresis. We started 5 years or so ago. The machines were held up in customs, so it was not possible to do a great job there. So, and then we lost it, and then we got it back 4 or 5 months ago and been doing it every day since. So this is all what we use. We also try to get at the superhighway in the brain by doing stellate ganglion blocks, which is the therapy for warriors. I see Dr. Mercola is trying to enter, of warriors at war with PTSD, but trying to get the parasympathetic sympathetic balance and congruence with life. And we do SOTs for cancer and for viruses as well. But this is what happens after we add therapeutic. In the olden days, we were letting blood. Now we're doing it in a fancier way. The machines are outstanding and easy to use, except please note, your nurses cannot do this. They are not trained to do this. This has nothing to do with IV therapies. They'll have to undergo six plus months of training. And that's, so you want to have someone else lend their expertise in terms of the training. So it's not something you can do overnight. This is what it looks like. And the question that I wanted to ask is, can you rapidly detoxify all the stuff in the plasma, which I'll go over in a minute, and then block the signaling that is pro-tumor and put it back into a neutral state at minimum so that you can have you can buy time. You're trying to buy time until the person sort of shuts down. And you've seen that all happen. I hear anyone that takes care of patients has seen some patients that simply shut down permanently. It's hard to bring back. So this is trying to delay that from happening. So this is a very old slide when I'm trying to understand why I am not insane by leaving academic medicine. It's not so much of the individual and the person. It's about the person with the individual organs. This has to be thought about in the system biology way. So apheresis, what is it? It's the same as plasmapheresis. It's the same as therapeutic plasma exchange. It's the same thing. We had this in Hopkins 50 years or so ago when we did lipopheresis for genetic elevations of cholesterol. So this is old-time stuff, but always in the hospital setting. So you take out the red cells, white cells, platelets, and plasma. Then you remove the plasma, you filter it out, and you sequester it. You never give the plasma back. Unlike EBU, when you're taking the blood out, you're adding ozone, and then you're giving back the same plasma with the addition of ozone. Wonderful technique, but you're still left with your own blood. So here you get back albumin, and you get purified albumin, and then you get back your red cells, white cells, and platelets. So there's no loss in the blood constituents. This is what it looks like. You can have someone in a reclining chair or in a bed. I won't get into the details of this particular patient now. There's not enough time. But you do get different clinical applications, but usually in the hospital. So now it's available in an outpatient setting, and it has potency, it has limitations, and I want to review all those for you. So how much do you get? You can measure the estimated plasma volume of somebody based on their hematocrit and ideal body weight, not your body weight with fat, but your dry weight. You can estimate it and then plug it into the machine and say, after I reach this certain point of 1 to 1.5 volumes, I want you to stop so you don't dehydrate someone and get back there. So usually in the literature that caught my eye in the year 2000, it was plasmapheresis can reverse cognitive decline. Two papers that can reverse moderate dementia. That caught my eye, because my hypothesis has always been, from the time I opened Anatomy Medicine 15 years or so ago, that Alzheimer's patients and dementia patients it's a summation of all their toxins, and it happens to represent itself in the brain. So if this was so, then apheresis should be effective. Then you get back 5% albumin. That's the one we use. We don't use anything else. I think FFP and cryopore plasma are rich with adverse side effects and not necessary. So it's really the bottom left. We all know this. We're all living longer. That's the main argument I get. Like, how come you say everything is so bad when our life expectancy is still in the 70s? Well, it's 6, 7, 8 years longer in Japan. How come that's the case? Well, you can just you can make baby mortality less, and get an increase in life expectancy. But we're getting sicker, it's clear. We have 4 or 5 ICU nurses that work with us every day, and they work in the hospital as well, and they tell us what's going on, and the level of morbidity, as you all well know, is very, very high now. So what's in the terrain? What's in the entire plasma terrain? This is not the micro terrain that we're talking about, although it's the same. It's the same as what Dr. Anderson was talking about in the micro terrain, in the tumor terrain. Well, this is what, in my background, where my parents spoke in Yiddish, this is called schmutz. And other people call it the swamp, but I'm not supposed to use those terms, as politically too sensitive. But this is what you try to de-swamp yourself with, or de-schmutz yourself. And this list is why we are where we are. And once you're a good oncology doctor, I'm not an oncologist. I'm a medical practitioner who's a cardiologist, and more relevant for this, I'm an immunologist. Since I have an NIH lab in inflammation, I have a bigger understanding of the system, but the system is now exposed. Every one of us has exposure to most of these things. And now we have 2-3 major things that make everything worse. We've known about mold making everything worse, predisposing you to worsening of all your natural deficiencies. And now we have the spike protein. On top of that, some of us have Lyme too. Some of us, we all have microplastics. We all have forever chemicals. Thank you for the water in the plastic container. But I am going to focus a little bit more, because I realize that this is a bit of a difference of opinion or of perspective on this thing called the cell danger signaling. This is what we're evolved to do. We co-evolved with viruses. Viruses are bad suckers because they can co-opt our own genetics to their benefit. That's their job. But we have to get over it, and then we have to move on. So there's something called the cell danger signaling system. It's teleologically protected for millions of years. In all your eukaryotes have it, a communication between the mitochondria and the outside world, and the mitochondria and the nucleus. So when you have a normal danger, which what is it? What is a normal danger? It's a UTI. Okay, what happens? Do you feel like running the marathon when you have a UTI? No, you're fatigued, you're tired, you clamp down, you recover with antibiotics usually, or natural remedies. And then you have to move on. So you have to regain what you lost. And you have to restore homeostasis. Well, then, if you lost some tissue because you had pneumonia and you have to rebuild, they have to go into a proliferative mode. And that's normal. So you clamp down and then you proliferate back. Now, we are stuck in either one of those situations. In cancer, you're stuck in the proliferative stage. But look, you have Lyme, mold, encephalitis, pandas, all the different drug-induced pathologies that we know very little about. And then we're stuck in that mode of being fatigued and constantly, bedridden. You have all the patients with our long COVID patients. And then in the proliferative stage, you're stuck in that stage. But there's no hormesis anymore. There's no balance anymore. It's stuck in that stage, and you have to unstuck it. So how do you unstick it? You learn about from Dr. Anderson and from myself and all the others, all the 3 days of misery and pain, because try to explain this to an oncologist, and you'll get the same silence that I did when I gave my lecture for full professorship at Hopkins, and I explained why 6 patients who were on the transplant list but couldn't get transplanted recovered when they were not supposed to recover. And that was the last slide. After I gave the state of the art of cardiac immunology, a room 5 times this size with a theater. And then I unblanked it. The intervention was 5-element acupuncture. Dead silence. My chairman is there. He goes, holy shit. What did this Israeli guy do? If you ever do that again, Dr. Herskowitz, you'll never make full professor here. I'm not going to even recommend it because you just don't get it. I said, I just wanted it. We had the renal people, the liver people, the eye people. Everyone was there. Why wouldn't they know? Because I thought it was stunning. I had no idea what 5-element acupuncture was, but 20 years later, I became one. Because now I understand that there is such a thing as energy medicine and so on, as something that you're taught in school. The only difference between me giving a lecture to the American Heart Association is that after the lecture, we're going to eat tuna fish sandwiches with potato chips. And when I teach at NCNM, there's pots and pans flying all over the place because they have to make their own food. So it's a different scenario. But the cell danger signaling is normal, and it's hijacked now because we're just overwhelmed with toxins. How do we do that? Oh, you can do chelation therapy, for which AAAMP is famous for. You can do binders for mold, but that's one at a time. Let's see what happens. What happens when you take them all out at the same time? Let's see. I don't know. Let's just see what will happen. 5 years ago when we started, we had good results. We lost it, and now we're doing it more systematically. It's very early. I don't have all the slides that I would like, but we'll start. But when you look at the terrain, you have the immune system, which we haven't discussed at all yet. All the autoimmune stages. This is, if you have life-threatening disease in the ICU on the autoimmune side, you're going to get plasmapheresis. You have end-stage renal immune complexes, you're going to get apheresis. You have ARDS and nothing is working, and you have a smart hospitalist, he'll give you apheresis. And then when you go to the older population, we all have pro-oncogene factors at this age. Metabolic syndrome, everybody, 84% and the major disinformation person is right here, Dr. Mercola. Hi. He's the one who told the world about this, and of course he was lambasted for it. Is all correct. And you get depressed mitochondrial function. So you have less to work with than you do as a teenager, right? Obviously. And so you have less compensatory systems. So this is my version of the cartoon. Oncogenes, pro-inflammatory cytokines. So inflammation plays a huge role, but it's only one role. It's metabolic too. It's senescent cells are supported. Senescent cell proteins that attract more senescent cells and can attract more senescent cells are easier to bring over to the tumor environment than normal cells. heavy metals, molds, but the spike is unique. This is man-made specifically to do injury in ways that were known and probably not known too, because it's an experiment in making everything worse. And we're running in the experiment. My job as a post-viral autoimmune guy was to say that, myocarditis this is clearly very tropic to the heart right away. We knew that in March of 2020 when everyone came back home to New York from Italy and from Europe. We knew that it produced myocarditis. That was nothing. That was the acute version. That's the active fulminant myocarditis. But then the post-autoimmune myocarditis will take years to manifest. So if it's post-viral myocarditis in general, you're not going to manifest it for 3, 5, 10 years later. And that's the reality. That's the reality we're in. But we also, interestingly enough, in the same reality for cancer, because autoimmune, if you know how to treat cancer patients, you know how to treat autoimmune patients. You know how to treat metabolic patients. You know how to treat any immunological condition. You know, because it's the same system that is trying to get out of that danger. Overwhelmed immune system, immunosenescence, inflammasomes, inflammaging, and whatever you want to call it. It's out of our number one thing is survival. Our number one thing is balance and hormesis. If you're not there, yeah. And probably the best prognosis for cancer patients is, can you walk briskly for 30 minutes? Are you capable of doing that? So a young adult and elderly, you have less to do. You have less tools in your toolbox that you have to reverse. And yet anti-aging medicine is reversing that elderly paradigm. That's what it is. No different. Anti-cancer lifestyle is an anti-aging lifestyle. You have no choice. You'll grab more people because they have no other choice. And you'll get a larger population, maybe 5% of the population instead of 1% of the population. And all these fanatics from Silicon Valley, where my center is close to, who want to live to 120 first. That's the Yiddish thing. 120. That's not good enough. Now it's 150. And then it becomes 180. And now it's, I want to live forever. Okay. You talk to yourself then, because you'll be the only one around. Because unless you deal with this, unless you deal with the tumor microenvironment, which is our microenvironment to a certain extent, with our different genetic susceptibilities and strengths and weaknesses that may become tumor, may not become tumor, but we all get sick. It's good to get sick because you train yourself, but it's out of control. Well, then you have to deal with this. This I'm not going to deal with now, but this is a better cartoon for me, but it's very similar to Dr. Anderson's cartoon. You're dealing with a symphony. Now, this symphony would sound completely chaotic. It would sound like this was made by the worst of the worst. It was by a kindergarten kid. It would sound very bad because it's not talking to one another. It's talking to the evil conductor. And you can check it out in your handouts. But it's also very acidic. The extracellular pH in the environment is very low. And when you're acidic in that environment, it happens to be the tumor cell cytoplasm is the opposite. But in the acidic environment, you have less protein synthesis. You have more growth and survival of the disadvantageous cells, the cells that like hypoxia and so on. And so you have more invasion and metastasis, all the things that we don't want to see. And then Dr. Anderson said in great detail and very successfully, the question that was asked was brilliant. I have a person who had stage 4 disease. He's under control. He's a win. He's got Natera results with circulating DNA that's 0,000. Typically, when you do that and you run the same thing with RGCC, with the circulating tumor cells, the circulating tumor cells are still there. They're not necessarily zero at the same time that the circulating tumor DNA is zero. They're on different kinetics. But let's say it's zero. Then you're left with someone with a predisposition to have their cell danger thing. They're beneath that level, but they're right there. They're not at zero. They're nowhere close to being normal. So yes, you treat them like they have a chronic insult. So when I first opened up the clinic 15 years ago, I asked my well-to-do clients if I could run an RGCC $1,000 OncoTrace test on them every month for 36 months. They were kind enough to do that. It cost them $36,000. And what we learned from that is you can go 0,0,003, 002, 00. What happened? Well, I'm a mom, I have breast cancer, and my son got sick. I had a stressor that put me back in the same cell danger messaging that put myself down. All the system was immunosuppressed. My NK cells went down to the toilet, and I reemerged on the tumor, but only locally. This was circulating. There was nothing to be found, and then it went away. And the long-term survivors, this is not the 30-year-olds who used to get cancer, because they have more of a survival. We don't see a lot of them. But now we have the turbo cancers in the 30-year-olds, and we see them, and they're worse than ever. What does a tumor do? A tumor cell has survival at its foremost. Unfortunately for it, you end up dying. So it dies, but at the same time, it has all the intelligence of a normal system does. So it co-opts it. It produces PDL. How do you get rid of PDL? I'm going to show you that plasmapheresis, of the things that plasmapheresis does, it does reduce your PDL circulating by the tumor cells. These are two of the papers that show that. Melanoma is one of the tumors, in my opinion, that's sensitive to immunotherapy. I mean, our version of immunotherapy. I'm not an immunotherapy person because I think it's a misnomer. It's a manipulator of the immune system towards one interleukin. And guess what? When I left Hopkins in 1995, there were 300 cytokines and chemokines. There are now over 500 cytokines and chemokines. So don't tell me if you reduce IL-17 that you're doing that. That's all you're doing. It's an interconnected web. And then you also can find PDL in the most intelligent way to give it. The most intelligent way to FedEx a package from one cell to the other is in an exosome. That's the most intelligent way. The future of therapeutic medicine will also include packaging your package, the one that you want, to target to a specific organ, because a specific organ has specific outward features on its cells. I want to target my liver, and I want to give it this particular message. It will be done via exosomes. This is what's happening now in the world. I don't know if you can even read this, but you can read the thing on the left, immune proteins and so on. Just read it on your own. We started off with lipoproteins. I think it's there. 50 years ago. And these people are alive today because of lipopheresis. But I had the former CEO of DuPont debating DuPont's role on a cruise with me, where I was speaking about anti-aging medicine, and he was speaking about the glories of science on the plastic side. And then he asked me to come to visit my clinic. So he got the message that I was giving. I refused his message. So you have all these things. What do you see? And this is again in the plasma. It's coordinated to turn on the danger signal. When I open the clinic, I ask the question, we have longitudinal data on hundreds and thousands and millions of people, right? We have it. It's in the VA. This is where I was professor at UCSF, working only at the VA. And we have it at Kaiser. Give me Alzheimer's patients who have it now, take me back 25 years. Take some element of a control as best possible that doesn't have Alzheimer's and take me back 25 years as best possible. What did I find? I mean, I wasn't looking at every single record that they had, but I found they're very good. One thing they're very good at is writing a complaint list. They have very accurate complaint list. If you have a stub toe, they'll put it there. You have toe fungus, it's always there. It's sinusitis, UTIs. The list was 2.5 times longer in the patients who developed Alzheimer's 25 years ago. It goes along with the hypothesis. It is our total toxicology burden. So now, if I was professor of cardiology at Johns Hopkins, now I could create a toxicology group of fellows that would study toxicology today. Because guess what? As a pathologist, I could find anything I wanted in that plaque. Everything and anything that you're looking for on this list, you can find in the plaque. Viruses, microplastics, spike protein, everything. So you can apply it to any given disorder, but it's there circulating in all of us. So what's in the filter? We know it has, and so similarly to EBU, it's a different filter. The timing is 2.5 times longer, and you're not getting back your own blood. You're not getting back your own plasma. So it's different, but it has certain quality. It's going through a very good filter. Well, this is what's known, and we don't know whether it has spike protein in it. The data with EBU suggests that it does. I don't trust a commercial lab to tell me whether they have spike protein or not. It's like I don't trust an NAD lab that tells me I'm going to get NAD with this. So I just don't trust it unless you show me the data. Oncogenic signaling molecules. We know very little about them. Of course, we know about PDL. We don't know anything very much about tumor-specific exosomes. I can tell you that each of the different tumor types have their own exosome signature. We will be able to measure that signature. That signature may be more important for prognosis than any single other measure. Because we know already, and I'll show you in a minute, I'll have 11 minutes left, but I'll show you that you can take a prostate cancer that will recruit adipose tissue and make it into prostate cancer cells vis-a-vis these exosomes. So then you have the thing that makes everything worse. This is the data that shows that you can see it in the EBU slide. This is not my data, but forget it. But now the question was, wait a second, you said we have two different paradigms here. We have the mitochondrial paradigm and we have the tumor microenvironment paradigm. They're the same thing. It's not two different paradigms. It's the same teleologically sensitive and preserved system that's preserved for our homeostasis, that's out of control because we've reached a tipping point. Dr. McCauley will tell you that we reached that tipping point in 1970. Some people will say, oh, it's the exact moment we put glyphosates in. No, it was everything. I gave grand rounds at Albert Einstein College of Medicine in 1979 on the rare disorder called Alzheimer's disease. It was new because it had a pathognomonic it's just one of the forms of cognitive decline. It's the most common, but it was, what's this? This is new stuff. It's not a prion. That's the only other thing we noticed. But it was new because it was in a younger person. But then you damage the mitochondria, you also damage telomeres. This is the green dots of the mitochondria. Suffice it to say, I do want to do other things. Suffice it to say that if you can drop the PDL1 level, you're going to do well with a tumor. And this is pre and post TPE with the message that would suppress apoptosis. So you want to continue that process, then reduce. This is what the checkpoint inhibitors are supposed to do. They do so with the same adverse side effects than chemotherapy does. Let's be clear about that. And then when you treat them and you don't treat their terrain and you don't treat anything else, but it's a win, then they develop lymphoma later. So tumor-derived exosomes, and this is just the exosome. This could just as well be from a normal cell. Every one of our stem cells in our body have the capability of communicating with their environment vis-a-vis exosomes. They don't communicate by wrapping their arms around you and giving you a big hug. They put out the message that they want you to see. This is around every arteriole of your body. And it was good enough to give us our life expectancy in the old days when we had parasites and we had wounds. And now it's good enough to give us the last 10 years of our life with relatively poor quality of life, but it's overwhelmed. So there's a lot of information in each of these exosomes. There's a PhD lifelong person, the 10 PhDs can use the rest of their lives going into all the different nucleic acids and proteins involved. But we can put whatever we want in the future into it. But this is the thing that shows that a prostate cancer cell can turn a fat cell into a prostate cancer cell. It's pretty mind-numbing, and how it communicates that vis-a-vis exosomes or tunneling proteins between cells. Everything and anything has been used, whether or not we've been able to see it or not. Because we see it in earthworms, it exists in us. So here's some data. I have some minutes. C-reactive protein goes down right away after TPE. Ferritin level goes down right away, which to me, in the setting of cancer patients, it is an activity marker. The lower it goes, the better you do. And in this case, the person already had failed chemotherapy, already plummeted her total cholesterol down to 90, and it raised it. It's the only case that we had that actually raised total cholesterol because it's lipopheresis is part of the plasmapheresis. So we have, again, the ferritin going down, the ApoB going down, HDL, all the different lipoproteins go down. So would ApoB is just the reflection of all the lipoproteins and the total cholesterol going down. So this patients like to do, even though this is not their problem. They shouldn't care about this except to say the lower you go with cholesterol, the worse you're going to be. It does have an effect on circulating immunoglobulins, and that's why in the standard of care in the hospital, we give immunoglobulin therapy right after. I had a lot of issues with that, giving a lot of side effects, and now the new way to give it is dripping it in, and you have much less side effects. So here's a more dramatic shift in IgG. But we don't know what the perfect thing is. We know that when we leave a patient alone with IgG of 497 with an autoimmune disorder, nothing seems to happen. Nothing bad untowards happens. And this is the one leukapheresis patient with chronic lymphocytic leukemia. It works. And it reduces the marker for mold activation, C4A, and Lyme activation. And here's a nasty picture. Here's someone who's metastatic disease to the neck, from a Mullerian source starting in the uterus, failed a portion of one chemotherapy round and standard of care. And then we got this glob of stuff. We took care of everything above the big new lesion here. So she defervesced. That's what it looks like when you have a mat of lymph nodes in the left side of your neck. Because we also injected it with ozone. We do a lot of things, but after we gave her, TPE or plasmapheresis, we noticed something happened right away. And that is, you take a lymph node in the neck. Lymph nodes in the neck can vary from 0.4 to 2.7 centimeters in normal people who have a viral infection, have sinusitis, but they're always black inside. Sorry. They're always black. And then it turns it almost immediately after the second or third TPE into something that's already admixed with connective tissue. So there's an infiltration of her tumor mass with connective tissue, and then the Natera results fall. And she's left with something that looks ugly but is not biologically active. The new one is. The new lesion is. But of course, you get your effects on rheology and things normalized. Like here's a squamous cell cancer of the mouth, rapid reduction. Every time she moves her tongue, she knows she has it, and then rapid reduction. And then she's left with a shelf here. This is after probably last treatment was a month ago, and she's been treated 3-4 more times and is gone to Natera of 0. And if this is, let's say this becomes a standard of care in the hospital, and then they'll get her to 0, it'll come right back because you're not dealing with the terrain. There's no naturopath there to tell you what to do, right? They're still giving lollipops in the IV suites. That's still the number one thing they give, although they went to Tootsie Roll time too, but they seem to have been, I think it was too expensive. So they went back to lollipops. Oh, this is the induced change with CRP. And albumin itself is anti-inflammatory. It's a very solid antioxidant. So you give albumin. And one thing you cannot get someone to do when they're in the hospital and they're cachectic, you cannot get them to give you albumin. It's too expensive. But in this case, obviously, you get it. So here's what it looks like. You get your bag, you get your patient hold the bag, they get to see it, they get to show their family. Everyone gets excited about this bag that weighs, 3-4 kilo, and it's full of stuff that we still have to measure and still have to document before and after, but this is what it looks like. But you look at the corner and the active autoimmunity looks milky, looks like you're asking I made everyone almost want to vomit when I said it looks like a mango latte, and everyone looks differently. But the point is, we already have data that's published on cognitive decline. Our own experience is this is a technique that's good for any large center that has the capability of having a specialized room to treat a whole host of different people. I always like to end with a quip. As a pathologist, I look at tissue as often as I can. This is an ugly rectal cancer of someone who couldn't afford anything. They just couldn't afford it. And you see some necrotic cells, and when you move over one view, you get all these cells here. What are these cells? These are eosinophils and mast cells infiltrating a rectal cancer that's constantly being irritated. He was treated and cured with ivermectin because he has parasites in there. So sometimes you can go with ivermectin alone, but I'm in complete agreement with Dr. Anderson. When you use the metabolic forms of repurposed medicines, you're keeping things in check if it works. That's all you're doing. You're not dealing with the stem cells. They're still there in whatever capacity. So the last slide I want to say is this one. All of you aspire to become master practitioners. This should be your motto. And this is what naturopathic medicine is all about, and that's why I asked AAMP to co-fund this, to be a co-sponsor of this particular group, because I think you guys understand what we're trying to do. And there's only a very, very small minority of MDs, and a lot of them are in AAMP. But if you don't know AAMP, we brought over chelation, of course. We're known for that. But we spawned off A4M. We spawned off the environmental medicine groups, almost every group, including all the ozone groups. But they have expertise and they deserve their full attention. But now A4M is 25 times larger because it's commercial. But we have the intensity that you have here from a perspective of AAMP's history, but our meetings are sort of just like this. Our next meeting is, I'm going to talk about it tomorrow in the morning for just a few minutes. Thank you very much.